Hi, this is Patty Corbett Ward, and I would like to welcome you to this presentation of Learning Thursdays, which is entitled, as you can see, Suicide Prevention and Substance Use Disorder Treatment. Our presentation today is coming to you by way of Brett Harris from OMH and Brenda Bannon from OASAS. You'll meet them in a moment. However, as always, I'd like to just give you a brief overview of Learning Thursdays. The series was developed as a way to offer free learning opportunities to professionals in our field with the goal of helping them improve the knowledge, skills, and attitudes necessary for the competencies that they're tasked to perform when they walk into their setting every day. This is a way to help people improve the lives of the individuals we work with in prevention, treatment, and recovery services. As always, folks, if you have any questions or concerns, feel free to send them to the mailbox noted on your slide. All that being said, I would like to thank Brenda and Brett for being here. And at this point, I'm going to hand it off to Brett. Thank you.
Thank you, Patty, for inviting us to this Learning Thursday. This is a very important forum to discuss suicide prevention, as substance use is the second most common risk factor for suicide. So speaking really to a substance use and substance use disorder population, I'd like to begin by talking about suicide, what the statistics look like, how it's impacting New York State, and then really getting more into what the tools are regarding suicide prevention in substance use disorder clinics and other settings that you guys may be working in. So as you can see on this slide, suicide is increasing. It's really a major public health problem that's impacting us today. And you can see, as compared to other, I guess, more common issues addressed by public health and public health practitioners, such as heart disease, cancer, and stroke, those are decreasing. So it's maybe because the funding has been focusing on those areas, but we see that suicide is increasing, that we need to focus on this. Now, the suicide impacts differently based on gender. So men are 75% more likely to die by suicide. However, women are more likely to make an attempt or be hospitalized and treated in an emergency department. So you can see that also by this slide that not only are we looking at suicide deaths, there's an exponentially larger number of suicide attempts that's really creating a problem as well, because people are getting injured and needing treatment, and so we can't just focus on the number of deaths that we were showing in the last slide, but also the hospitalizations and emergency department visits. Now, people always tend to look at it by age and focus on youth, and if you were just to look at the number of deaths by suicide, you would see that it's less of a problem among youth. The larger numbers of deaths, they increase into middle age. But you can see that, as I was talking on the last slide, the hospitalizations and emergency department visits for suicide attempts, those are larger among youth, significantly larger, and then decrease as in the older age categories. And also looking at youth, so the Youth Risk Behavior Survey by the Center for Disease Control and Prevention asked high school students a number of questions, and specifically among New York State high school students, 29% reported feeling sad or hopeless, 16% seriously considered suicide, 10% attempted suicide, and 4% had a suicide attempt that had to be treated by a medical professional, meaning it was that serious. And this all within the 12 months prior to them taking the survey. And then this is a really important image here, because we can see how this breaks down by race and ethnicity, as well as gender. So you can see the bars that are really towering above the other is among white men. And particularly white men in middle age. So you could see that it increases up to middle age, kind of decreases slightly, and then goes up in the old age, 85 and above. White women, for comparison, because they're much higher than women of other races or ethnicities, are much lower and actually comparable to men of other races or ethnicities. The pattern is slightly different among black men. You could see that it's more of an issue among younger men, and then it starts to decrease. Whereas among the white men, it increases up, as I said, to middle age. So if we were going to say what is the population that's most impacted by death by suicide, you would say white middle-aged men. Another way to look at this too is by urban and rural designation, because they're really very different problems. And just looking at it, so nationally, the majority of suicides are by firearm, deaths by suicide. This means is the most lethal, so therefore resulting in the most deaths. In New York State, that's not the case. Suffocation is the means it's used most for suicide. But if you look at it by the rural areas, that's by far the most, the greatest means is firearm. So just breaking it down, you can see a totally different story. And the rate of suicide, it's much higher in rural areas. So if you were looking at it based on total numbers, of course, there are more deaths by suicide in urban areas. But it's because rural areas are just so sparsely populated, but the rate is much higher. And the one category, other, where the rate is higher among in the urban areas, that's really about jumping from a high place, so typically jumping from like a tall building or a bridge, which is actually definitely a point that that in public health we're looking at to address with regards to suicide prevention in urban areas. And as you can see from this graph, this is really a color chart of the state by county, and the darker the color, the higher the rate of suicide. And this is really the urban versus rural divide again here. So the more rural and sparsely populated counties are the ones with the highest rates. And though we have the largest number of suicides in the New York City area, they have very low rates of suicide. So suicide and unintentional drug overdose rates, they've been increasing together. So now we're in this era, this opioid crisis that we're facing. This is a very important issue because the suicide and overdose are very closely related. In fact, many of the overdoses may actually be suicides, but they don't necessarily know, it's an unknown intent. And also people that are using drugs to that extent, a lot of them know the risk and they're okay knowing that risk. Yet, so in a way that's like a passive suicidal behavior. And as I was talking about earlier in the presentation, there are many issues that are facing us today, and public health tends to focus on other ones. But right now we're being impacted by what are called deaths of despair. So this is suicide, drug overdose, and actually alcohol-related liver disease. So focusing specifically on those, because those deaths have been so great that they've actually been overturning, so causing all-cause mortality to actually increase in the United States. So just think back to that slide I showed at the beginning, and we still see that blue line above the black parallel line, showing that suicide's increasing, but you add drug overdose to that, and it's that you could see just how great of a problem this is, because that line towering above the rest is drug overdose. And something that's really underlying this, and I know this says 50 to 54 because this was the focus of an article. They're really talking about middle age, but this is also for all age categories. white mortality for these deaths of despair, so we're talking about drug and alcohol poisoning and suicide, is greatest among people with a high school education or less. So there's definitely an issue in that you could either say education level or socioeconomic status. And you can see it just towers above. So that's a major divide in how this, how suicide and drug overdose is impacting our population. And now compare this to other countries that are similar, and they're all developed countries. The red line is the United States, and it's greatly increasing. And while the other countries, it's decreasing or not nearly as high. Now, this slide, I know it's very busy, and the main purpose of this slide, as I was just saying on the last slide, this was a report by Case and Deaton, and it was originally from 2015, but updated in 2017. So the 2015 article was focusing on middle age, and this one is now showing that, wow, it's not just middle age, it's in every age category. So you could see that the slide, they go by 10-year ages across the slide, and every single one you can see on that red line is increasing, whereas the other lines, once again, there are other developed countries, are decreasing, not nearly as high as the United States. So now that we covered kind of what suicide looks like and how it's impacting populations, Brenda, as the suicide prevention liaison from OASAS, why don't you explain to us how really suicide interacts and intersects with substance use?
Sure, I'm happy to do that, Brett. So suicide and drug overdose, as you've seen, are both really exponentially increasing. Now, drug overdoses are primarily opioids, and they've tripled since 2010. We know that the opioid crisis is a problem for New York State and for the country. Injection drug use increases the risk of suicide 14-fold, but opiates, including heroin and prescription painkillers, are present in 20% of the suicide deaths in the United States. Substance misuse and suicide, outside of depression, substance misuse is the second most frequent risk factor for suicide. Alcohol misuse is the highest risk for suicide, but other drug use also is a high risk, which makes it very important for the substance use disorder provider system to be aware of and address. So alcohol misuse or dependence increases the risk of suicide tenfold, and 22% of the deaths by suicide in the United States involve alcohol intoxication. Alcohol intoxication is present in 30 to 40% of the attempts. Also present at the time of death is marijuana at 10%, cocaine at about 5%, and amphetamines at about 3.5% or 4%. The number of substances that are used are more predictive than which substances are used, and again, the only outlier for that is alcohol intoxication, which is a very high risk for suicide. There were 230,000 emergency department visits from drug-related attempts in 2011. Almost all of them were involving prescription drugs or over-the-counter drugs. The ED visits for drug-related suicide attempts increased 51% between 2005 and 2011. The connection between substance use and suicide is very strong, and it's almost parallel. With substance use, there's disinhibition during intoxication. It can increase depressed mood. Alcohol, again, increases proximal risk. And alcohol also can increase psychological distress, aggressiveness. It can propel suicidal ideation into action. In some ways, for instance, someone who is intoxicated may think that following through with the act of suicide may be less painful or not painful at all because they're intoxicated. It also constricts cognition. It impairs the generation and implementation of coping strategies. So substance misuse is a primary risk factor for both suicide attempts and completed suicides.
So Brenda, is there something that our audience can read about how to address substance use and suicide together?
Yeah, there's a great article that came out in 2016, right? 2016. And it was a SAMSA brief, and it's entitled Substance Use and Suicide, a Nexus Requiring a Public Health Approach. The primary sort of focus of the article is the importance of the professions of suicide prevention and the substance use disorder prevention professions coming together and integrating care, because it provides a much more effective what would we say, intervention, I guess, for suicide and SUD.
So now we're going to introduce the zero suicide model. So what is zero suicide? Well, it's really a commitment to suicide prevention in health and behavioral health care settings, but it's also a specific set of strategies and tools. So New York State has made a commitment to be a zero suicide state. And so now we're going to introduce the zero suicide model. So Brenda, why don't you get started and explain what the elements are?
Okay. Well, there are 7 elements in the zero suicide model. And the zero suicide model can be implemented in behavioral health as well as physical health settings. So primary care, emergency departments, substance use disorder clinics, mental health clinics. The 7 elements in the model are lead, train, identify, engage, treat, transition, and improve. The lead element is important for leadership of the organization to really be on board with the zero suicide model. They provide leadership to create a culture where suicide prevention is attainable and that the possibility of zero suicide is real. The leadership of the organization is the one that sets the tone, so it's important that the leadership lead this sort of charge. There is a belief that suicide can be prevented and that it's everyone's job, not just one individual person or clinician, and that it's more of a systems issue. There is an emphasis that changes suicide prevention or intervention from liability and fear or blame on a single person to a team approach of confidence and competent care and the ability to address suicidality.
So Brenda, do you feel like, because you're talking about removing that fear, is fear an issue with addressing suicide?
Absolutely, particularly with our substance use disorder providers, but I think in every treatment setting, individuals are afraid. I think the belief is that if we ask the question, if someone is feeling suicidal, then what if it gives them the idea, or what if it encourages them to complete a suicide, so people become fearful that they'll be responsible if there's a completed suicide for one of their clients or for someone that they're caring for.
Especially if they don't have the training or don't feel comfortable doing something, if they identify any kind of suicidal ideation.
Absolutely, because if you ask the question and get a positive response, so you have someone in front of you with a high risk and you don't know what the next step is, then that's a really difficult predicament. And most of our providers, the solution has been to, call the police, have the person sent to the hospital, and then they're evaluated and admitted and held in, an inpatient facility for a few days to be evaluated. And we know now that that's not particularly the most effective way to intervene in suicide risk or suicidality. So the second element is train, and that's what we were talking about. It's important to have a competent workforce, and a workforce that is confident that they can, in fact, use the tools to intervene in an effective and positive way. So training is knowing what and when to ask about suicidal thoughts and behaviors, knowing what to do if you encounter someone who screens positive for suicidality or a high risk of suicidality, and also having a sense of comfort and confidence in your own ability to interact effectively with an individual who is exhibiting suicidal thoughts or ideation or behaviors or high risk. And having the ability to know how to intervene or connect to someone who can intervene effectively is very important. I don't think any of us feel comfortable in any situation that we're not sure what the next thing to do is. So in Zero Suicide, there's training provided that is appropriate to each role or level in the organization, and gatekeeper training is for any individual that has client contact. So that might be the receptionist or the scheduler, or even the billing person may be gatekeeper trained. And there's more in-depth training in screening and risk assessment, suicide-specific evidence-based interventions like CBT-SP or DBT or CAMS, follow-up monitoring and increased contact, and smooth referrals and connection to additional treatment.
So just for our audiences, because typically Brenda and I are well versed in suicide prevention, but gatekeeper training, if anyone's interested in knowing what gatekeeper training is, there's a few different kinds. One of them is question, persuade, refer, or referred to as QPR, which is really the least intensive one. It's about an hour and a half long. There's one called Safe Talk, which is about 3 hours long, and then there's another one which is pretty intensive, which is 2 days long, called Assist. Really, those are put on by Living Works and provided throughout the state, so that might be something that staff who don't have clinical, who are not providing direct patient care might be interested in partaking in. Of course, Assist is more intensive, so maybe some people do have some clinical, I guess, clinical activities that they engage in would benefit from Assist.
And those are the amounts of time it takes to train for those techniques, not necessarily how long time it takes to administer them, the QPR, right? So those are simple techniques.
Trainings, right? Assist is applied suicide intervention skills training. As we all know, there's so many acronyms.
They certainly are.
Just wanted to put that in there.
But I think it's important for our providers to know that, particularly that the QPR or the assist is more intensive, but something like the QPR is a simple technique to be able to use, and that you don't have to be a clinician necessarily to intervene with that. Okay, so the next element is identify. So there's screening to identify suicidal thoughts or behaviors. It's a standardized screening that we recommend for all clients, and it's the CSSRS or the Columbia
Suicide Severity Rating Scale.
I can never remember
so
that.
This is the screening tool that we tend to use and promote fairly often in New York State, so definitely one to check out. It's available online. There's also an assessment in the version, so a longer version of the CSSRS. And formal risk assessment is very important to be conducted by trained clinicians for clients who screen positive. And this assessment, you're looking to find out not just ideation, but also current and prior behavior, a plan, a method, availability of means, acute risk factors, and so forth. So by asking these things, you can really figure out what the risk level is. And that'll be important for determining what kind of intervention and what kind of treatment that a patient gets. Stratification of risk is determining that risk level, as I said, and based on the assessment. And then reassessment. This is so important because risk fluctuates. Ideation fluctuates. So at one point, someone could be seriously thinking about suicide, and another point, just a short time later, no. So it's important to keep asking at visits about this and assess the level of risk.
I think it's important to really focus on that too, that suicide risk, it ebbs and flows, so that we have peaks and valleys when someone is struggling with suicidal thoughts or ideation. Then they have times where it's high risk and times where the risk is much lower. And I think most people don't think about it that way. So it's getting through that peak and then into one of those valleys where the risk is lower that is saving lives.
Yeah, and that's also an important thing to mention too. So there's screening tools for a lot of different things, and there's and so for our audience, there's screening tools for alcohol and drug use, and those tend to be more steady. Like it's not a momentary thing where someone's drinks 5 glasses of wine a night, and then the next week they're not doing that. That's less common, but it's not the same for suicide, as that really does fluctuate, which is why we stress the importance of screening all clients at every visit. So that should be really providing suicide safer care in health and behavioral health care settings. So just to introduce the CSSRS, so what is this? It's a fairly short screening tool, and there's 6 questions, and you can see that the question intent is on the left and the response is on the right. So what do you do based on the response? So the first question is getting at the wish to be dead. The second one is suicidal thoughts. The third one is suicidal thoughts with method. So that's with the method, but without a specific plan or intent. So they haven't thought about how they're going to do it or what their intent to actually do it. And next one is suicidal intent. So they are planning on doing this, but they do not have a specific plan. And then question 5 is suicidal intent with a specific plan. So that's very high risk, and would recommend behavioral health consultation and patient safety precautions. Question 6 gets at the recency of this. So suicidal behavior not within the past 3 months, or suicidal behavior within the past 3 months. So lifetime behavior is less risky than immediate current behavior. So what do we do after that screen and assessment? We need to engage the patient. So it's critical for healthcare systems to identify I guess, a pathway to care. So how does a patient get on this pathway? So,
Brett, can you explain a little bit what a pathway to care is in suicide prevention and treatment?
well, it's really for a healthcare organization and the staff to identify when a patient should be getting suicide-safer care. I mean, really everyone that come in should be getting this care, but we have, we want clinicians as part of this model as we'll get to be trained in specific interventions. And how does a patient who identifies some sort of risk end up getting those services from the clinic or whatever they're receiving services? So that pathway is, okay, so someone screens positive, they answer these certain questions on the assessment, they're kind of on that pathway and get into care. And then at a certain point when they receive treatment and they're doing better, what is that protocol for getting off the pathway? So we need to, standardizing a procedure like this is just critical because it really it's such a serious issue that it takes the guessing game out. So there really should be some protocols in place to determine that ahead of time instead of really relying on a case-by-case basis.
So it's kind of a care management plan for the suicide risk.
Yeah, so once they are identified, they get this care management plan like you're talking about. So these patients, what's on that? So as I said, a frequent reassessment of risk because of the fluctuation of risk. Safety planning and means restriction. So I'll briefly get it. So safety planning is really a brief intervention that includes means, as actually we call means reduction now, which is really saying that if for example, poisoning, like through overdosing on drugs or firearm deaths, those are ways that people use for suicide. So taking those means away, so maybe locking a gun away if someone is at risk. That's what I mean by means reduction. Crisis response if needed. Increased contact or follow-up and monitoring. So these are really important too because, and a lot of times we encourage that the patient be an outpatient so you can stay within the community. So following up them when they're not and monitoring them when they're not in care. And then, of course, best practices for appropriate level of risk, which we will talk about momentarily. So treat is so technically what we historically tend to think that patients who are thinking about suicide, they're depressed. So we want to treat the depression, and if we treat the depression, people will the suicide risk will just go away. And it's the same with substance use too. So if someone is maybe it's the substance use that's causing people to think about suicide, and if we just address the substance use issue, then the suicide behavior will go away. But that's not the case. We don't want to target these other things solely. We want to target directly the suicidality. And then also, as Brenda was alluding to before, we want to provide care in the least restrictive setting possible. So instead of identifying someone that's thinking about suicide and all of a sudden locking them up in an inpatient facility, we want to make sure that we do properly care for them, but we want them to remain in the community. Because in the past, and what tends to happen is that patients will not be open and honest about what they're thinking because they don't want to be locked. They don't want to be taken away by the police and locked up, so they're just going to not be honest. There are ways to keep them safe, and as they can be out in the community, they'll be I guess most comfortable and most, pretty much most comfortable and where they want to be in the community rather than in a hospital setting. So we're looking at interventions that are empirically supported for suicide prevention. So something as simple as non-demanding caring contacts, and yes, phones, postcards, and letters to patients shows that someone is thinking about them and cares about how they're doing. So this would be provided by the healthcare system, the clinic that is currently seeing the patient. And there's been research that actually shows the effectiveness of this. So this is why this is being stressed not only by us, but by the Suicide Prevention Resource Center, which is really a national clearinghouse for suicide prevention. There's the safety planning intervention, which I alluded to before. This is a brief intervention, and it actually covers, there's about 6 steps to it, and I'm covering that on different slides. There's the cognitive behavioral therapy for suicide prevention, or CBTSP, dialectical behavioral therapy, collaborative assessment and management of suicidality is available as a module online, and actually we were able to provide a number of OASAS providers access to this training, and reducing access to lethal means, which I described previously, and there happens to be a training on this available free of charge online at the Suicide Prevention Resource Center's website. Now, so the safety planning intervention is something that it's not just a general safety plan that's put in place for any kind of situation. This is particular to suicide prevention, and it's a collaborative process where, so it's really a brief intervention which is conducted with a trained provider face-to-face, and they develop the safety plan, and there's actually an app available too, so that the patient can put the information that's been collaboratively developed as part of their safety plan in their phone and be able to access it at any time. It's not, they don't have to carry the piece of paper and maybe lose it or something. It's on their phone.
And it's not something that's prescribed to the patient. It's something that the patient helps to create them.
Yes.
With the clinician.
Yes, it's really the clinician is in the background really trying to direct this, but the patient's really developing it with their own experiences. So the first thing is identifying warning signs. So what are those warning signs? What are they feeling and thinking when the suicidal thoughts come into their minds? So that's the first step. So the second step is internal coping strategies. So the patient's really asked to think about what they can do internally to cope when they start thinking about suicide. So for example, they could listen to music, or they could go to the gym, or go for a walk outside. And then the next step, so this is really like a stepped thing here. So they start out at what, if they're thinking about suicide, they identify those warning signs, they're thinking about it, and they start with those internal coping strategies. They'll listen to some music. If that doesn't work for them, they go to that next step, so social situations and people as distractions. So you're not seeking out someone that you can say, you know what, I'm thinking about suicide, I need help. This is something just for distraction. So you can go hang out with a friend and just talk about anything, just to be distracted, or you could go to a coffee shop where there's other people around, so you're in the social situation, you're not by yourself. If that doesn't help you, you go to the next step, and that's people to ask for help specifically this time. So maybe it's a family member, a friend, significant other. You can ask these people for help. And then the next step is identifying and having on hand a contact for professionals or an agency that you can go to for treatment, for intervention and treatment during a crisis. And last and very importantly is making the environment safe. So like saying before, it's reducing access to lethal means. So if someone's a gun owner, it's okay, giving that gun away to a friend or a family member just to store it away during the times when they're in crisis or thinking about suicide. Or you have pills in the medicine chest, making sure that you don't have access, giving that away to somebody.
And this, again, goes back to the ebb and flow of suicide thinking, because it's the safety plan is getting through that peak and hopefully getting to a point where you're back in one of the valleys where things are calmer and less crisis situated.
Yeah, because a patient who's at risk for suicide we want them to be in the community. And they're not going to be with someone at all times. It's just impossible, really, to watch over someone at all times. This is really empowering them and having tools to deal with their situation, because really a lot of people that are at risk for suicide, it doesn't go away with one treatment or one visit to a clinic. It's something that stays with them, and as you say, ebbs and flows. And this really gives them the the tools to deal with it when they're not in a clinic with trained providers.
And we know that it ebbs and flows over a lifetime as well. Excuse me. So they may be suicidal as a young adult and then not experience suicidality again until they're in their middle age or elderly.
The last thing I'm going to touch upon with zero suicide is the transition element, because it's so important for providers to ensure a warm handoff, because the time of greatest risk is right upon discharge, really from an inpatient setting, and also when they're just in care and going out of care. So in that time of increased risk, it's important to provide more contact, so duration of contact, intensity, and frequency, and then the follow-up and monitoring. So once again, those non-demanding caring contacts, and the phone, letters, postcards, and nowadays texts. There's healthcare organizations are using texts, and people prefer that method of communication. And look out for people as well, and make sure you monitor people who miss appointments or you have difficulty scheduling appointments with. Provide referrals. So between services, for those who are scheduled for care, and those and to engage those not actively engaged in care. And then, as I said, after discharge from acute care settings, because there they are in they've got 24/7 care, and then they're out in the communities. That's definitely a very high risk period.
Any transition period really is a risk, right, for our clients.
So New York State has been very active in supporting and implementing zero suicide. And for the past 3 years, recently just ending, we had a National Strategy for Suicide Prevention grant through SAMSA. So National Strategy for Suicide Prevention in the suicide prevention field lingo is NSSP. So we've had this grant, and it was a 3-year grant in the catchment area of Erie and Monroe County in New York. So this area is has one of the highest burdens of suicide in the state. So what I mean is that the number of suicides is very high in comparison to other counties. There's only a few other counties outside of New York City that have higher numbers of suicide. So the zero suicide was implemented in specific settings in those counties, and we also implemented some learning collaboratives. So we had a learning collaborative in some of the OMH licensed mental health clinics. And after that learning collaborative, we used lessons learned and tailored it to address substance use disorder outpatient clinics in those counties. Brenda was really key in implementing this and getting OASAS involved and getting the sites on. So Brenda, why don't you describe how you got the providers to join this learning collaborative?
Well, when I was brought into the project, we reached out to the providers in Western New York, in Erie and Monroe counties, and we had a webinar introducing what the Learning Collaborative would be and explaining a little bit about zero suicide and the plan to provide zero suicide training and work with the providers to adapt that model to the substance use disorder clinics. It was outpatient clinics that we focused on, and it was a 1-year program or project. We had 6 providers that decided to join the Learning Collaborative and worked with us for the 12-month period. We had an upper-level administrator and clinic manager for each of the providers, and and we did the adapted Suicide Prevention Resource Center Workforce Survey with all of our providers at the beginning and at the end of the collaborative, right?
Well, actually, as Brenda was saying this, I do want to take a step back and talk about some of the tools available to help implement the zero suicide model. And so the lead step, there's a zero suicide model toolkit available online, and I'll have that link for you at the end. But there's the organizational self-study, which helps to identify where an organization is really on that lead step, to being ready to implement zero suicide protocol. And that's available in the toolkit. It's a pretty thorough survey that we used with the Learning Collaborative and adapted it for substance use disorder clinics. There's also a workforce survey. So this is to be filled out by all staff, not just the ones that provide direct patient care. And it really gets to the point of what services are provided and what kind of training they currently have. We administered this a couple months into the Learning Collaborative as they were thinking about their timeline for implementation. And so this survey, I actually am going to show you the results for. So we asked them if they'd ever worked with a client who had died by suicide and attempted suicide. Yeah, the answer is yes. So about 1/3 have worked with a client who died by suicide, meaning that they have lost a patient, which is very challenging for the workforce in and of itself. And 3/4 have worked with a patient who have attempted suicide. In fact, a lot of them have worked with more than one patient who has died by suicide and attempted suicide. So really what this says is that the staff at that treat substance use disorders in the OASAS clinics, they are dealing with this issue. So yes, this is an important issue to address and to provide training and support for.
When you think about 1 in 3 of our clinicians who have, at least of the ones that we surveyed, that had actually had a completed suicide with one of their clients, that's a lot of our clinicians dealing with a traumatic loss. And our clinics, and I think probably it affects the entire agency when there's a loss like that.
Yeah, and let me just underscore too that, as I did say, this survey went out to all of the staff at the, so not just the people that were in the Learning Collaborative, it was all the staff that work at the organizations that participated in the Learning Collaborative.
Right.
And they have received some training in suicide prevention. You can see that the orange bars are more recent trainings, last 12 months, and the blue bars are ever had training. So as you can just, in general, what you see here is that about 1/3 have had recent training and 2/3 have ever had training. So really what we have is 2/3 of the staff that have not had recent training, and it's important to really brush up on these skills because this is such a critical issue. So as I say, about 1/3 don't feel that they've had the training they need to help clients with suicidal thoughts or behaviors.
And we know that it's important that even if you have the training, that the training is completed regularly, at least within the last 12 months, so that your skills and the tools available stay familiar and you're able to use them.
Now the question of when does the staff bring up the topic of suicide? So remember what I said earlier, we want to bring it up at every visit with all clients. So only 15% are actually doing that now, and that's really a cause for concern. We don't expect the providers and the clinicians to just have thought of doing this because, in their background and training, they're addressing substance use, not suicide, and it hasn't really been brought to really leadership's attention or the attention of clinicians, and that's what we're trying to do now. So that it's a cause for concern, but it's something that we want to address. Only half were bringing up suicide at every visit with clients at elevated risk for suicide. And then 77% were bringing it up when a client's record indicates any history of suicidal thoughts or behavior. So still over 20% were not when they have a record of it. So that really could be an issue of fear. So if they see someone has this, they really don't want to talk about it. They kind of just avoid it. Even when they suspect that a client is to be at elevated risk, there's still 15% that aren't bringing it up. And then with all new clients, only 77% are. It's important to bring it up with all new clients particularly, but then again, the best practice is to bring it up at every visit with all clients.
Again, and I feel like I'm sort of beating a drum with this, but again, it goes back to the fact that suicidality ebbs and flows, and someone can be in a non-crisis point having with their suicidality or suicidal thoughts, and then have it peak. And if you're not asking at every visit, you're gonna have a much higher possibility of missing that. And I think, how many times do we have a completed suicide where the loved ones are absolutely astonished that the person would attempt or complete a suicide because they're not exhibiting those, they're not advertising that to the world that they're suicidal or that they're thinking about suicide.
Mm-hmm. So the practice frequency. So this is, now you could see the numbers on the bottom just to get an idea. So they were asked from 1 being never to 5 being always, how often they practice certain things. And so when you're looking, we have the averages down here. When you're looking at something that's about, let's say, 3 is about, about half the time. So we have screening existing clients for suicide risk with a standardized measure. So something like we talked about, the Columbia screen, the CSSRS, less than half the time people are using some kind of measure. Which it's really often hard to identify risk if you're not using something that's standardized. Fewer are involving family members and friends. It's very important to involve family members and friends in care. A little more than half the time people are screening new clients for suicide risk with a standardized measure. So once again, it's important especially important for new clients when you don't know what their risk level is. Conducting a standardized risk assessment for those at risk for suicide, and asking existing clients directly about suicidal thoughts and behaviors. The thing that's done most frequently is gathering information on risk and protective factors from potentially suicidal clients. Now, so next steps for us. So we learned a lot from this learning collaborative, and
yes, we did.
We want to implement zero suicide and SUD programs based on lessons learned. It's important for us to raise awareness of suicide safer care for these treatment programs. Like I said, the numbers of suicide safer care is really, and the way that we would like to see it, is not being conducted in the SUD clinics, but it's also, it's really also not being conducted really anywhere else. So we're focusing on doing this by raising awareness. We want to provide education and training, and we want to promote suicide prevention as drug overdose prevention. Recently, the New York State Office of Mental Health Suicide Prevention Office was awarded a zero suicide grant from SAMSA. This is a 5-year grant, and it's the first time they've had this grant. And it's there were 3 awards, and New York State was the only state to get it. So we're very we're proud of that, but we're also very encouraged that this can help us advance zero suicide in the state. So we're implementing zero suicide in every single one of the 5 OMH mental health regions in the state, and we're going to do a special zero suicide safety net in Onondaga County, really, where we're going to be implementing zero suicide in multiple different practice settings, including SUD clinics in the county. So with that in mind, we're going to use really what we've learned with the Learning Collaborative and following up with those providers to tailor this to Onondaga County and really use the grant efforts to implement it there and see how it works and tailor it and get it to work. And continuing this relationship with OASAS is critical. And I think that we've developed a good understanding of the importance of this between agencies. I mean, we're unlike in some other states, our agencies are separate, but we want to make sure that those silos don't stop us from addressing this issue, because they really, as we said, they go hand in hand.
And it has been a very, very exciting prospect for us. We started this project with a learning collaborative, but our collaboration continues in addressing both SUD and suicide, and it's so exciting because there are so many of the risk and protective factors with substance use disorder is also the same for suicide. And again, those two are sort of on parallel paths. The opioid crisis that we have with the overdoses and overdose deaths that are rising and taking so many lives. When we looked at the slides earlier, we could see that overdose deaths, they're the only thing that have surpassed suicide deaths recently. Everything else has been going down. So it's really important that we collaborate. And in New York State, we're able to do that. We have a great working relationship, and it's very exciting to think that we can implement suicide safer care in our substance use disorder programs and save even more lives.
And also, we also talk about prevention going beyond the substance use disorder population. That we're very interested in suicide prevention in different areas of OASAS and prevention, and really integrating that as well. So I think that we can really do a multi-pronged effort, and so moving forward, really that's where we're looking to work and to really make inroads.
As we plan for the future.
So I just want to end with a few things, some tools and trainings available. So I mentioned the Zero Suicide Toolkit, and this is where you can access it. And there are a bunch of different tools available within that, and videos as well. So the organizational self-study, which helps with the lead element, that's in the toolkit, and the workforce survey, which helps with the train element. And actually, the Zero Suicide Toolkit now provides those surveys electronically, so that you can just have people fill it out right on their website. So you don't even need to put it in either on the paper or on your own survey instrument and software. There are free online modules from the Suicide Prevention Resource Center. I mentioned one of them, that Reducing Access to Lethal Means. That's a very useful training. There's the Collaborative Assessment and Management of Suicidality, or CAMS, which I had mentioned, that a number of OASAS staff have accessed and completed. And then there are other online modules available from the Center for Practice Innovations, which are available free of charge for OMH licensed facilities and now OASAS as well, right, Brenda?
Yes. So it's really amazing to me, prior to becoming a part of the Learning Collaborative project, I was familiar with the Suicide Prevention Center and their work, but I was not familiar with the number of tools and trainings that are available really at free or at a very low cost with suicide prevention and zero suicide and suicide safer care. So I think it's very exciting to have those tools available.
And those online modules that are available for free of charge include screening, so that using the CSSRS, there's a training on that. There's one on safety planning. There's one on follow-up and monitoring. They also have regular trainings provided, like on risk assessment. So there are tools out there available to access at any time that you can do right at the convenience of your own computer. So another announcement is that we're having our Suicide Prevention Conference on September 20th and 21st. at the Desmond Hotel in Albany, New York. And we hope that you can join us for that. And so that's called New Yorkers Advancing Suicide Prevention in Healthcare, Schools, and Communities. And
it was a great conference to attend, so I'm really looking forward to being able to participate again in the conference. There's a lot of great information, a lot of great speakers. I would highly encourage anyone who's able to attend.
Great. So here's our contact information. You can feel free to follow up with us if you have any questions. And once again, I want to thank OASAS for inviting us to present on this very important topic, and as well Brenda for joining me.
And I'd like to thank Brett for being willing to come and provide information on this topic. And I'd just like to thank you for being such a great partner. The partnership that we have between OASAS and OMH, and particularly in this area, is very exciting and has been so fruitful so far. So I'm very excited for the future with us, and I'm very thankful to be a part of such an important project.
So again, Brett and Brenda, I want to thank you, and I especially want to thank you for presenting on a topic that you noted during the presentation that people are fearful of broaching. And what you talked about in part are the consequences of not talking about this topic, so thank you. And to those of you who've joined us, if you would like to offer some feedback, please take a moment to complete the survey at the SurveyMonkey link located on the slide. Thank you always to Media Services. As I tell you all the time, they put in a lot of time and effort to make sure that you all receive a very professional presentation. Thank you for joining us, and we will see you again.